You're tuned into Recovery TV, the voice of hope, with your host, John J. Tassoni Jr. Discussions and information on addiction and mental health issues. Now, here's John and today's guest.
Welcome to Recovery TV, and I'm your host, John Tassoni. Today, my guest is Sharon Morello, who's a nurse, a consultant, and a trainer. So welcome, Sharon. Thank you for joining us today.
Thank you, John. I'm glad to be here.
Well, one of the reasons why I asked you to come is because some of the classes that you teach is very interesting in the realm of pregnant women. We're seeing a lot of pregnant women addicted to opioids, addicted to a number of different things, alcohol, and the list goes on. So give us a little bit of background on Sharon Morello from my viewers, and then we'll get right into the discussion.
Yeah, sure. So we've had, and we're beginning to see an increase of overdoses in pregnant women. We're beginning to see a lot of things happen with pregnant women, not just overdoses, but increases in other things on the mental health side as well, as we're seeing with the general population. But pregnant women not only during their pregnancy, but the whole first year postpartum. It's not just 3 months after. They're actually calling the first year after delivery, they're calling it the fourth trimester at the national level. So there's 3 trimesters in a pregnancy. We've just added the 4th one, which is the postpartum period that includes a full year. In fact, the increase is the highest rate of overdose and deaths in pregnant women is not during pregnancy, but 7 days to 365 days after delivery, which is interesting, isn't it? So we've been talking a lot about opiate use disorder in pregnant women, and we've been caring for pregnant women with opiate use disorders with evidence-based research from back in the 1960s, 70s. By 1972, we already had protocols in place for pregnant women who had opiate use disorder to get onto the only medication that we had available at the time, and at that time that was methadone. The research has shown since 1975 that this is an evidence-based practice, yet we continue, like we know, to have stigma around people who take medications for their substance use disorder, even though it's been evidence for a long, long time. We're doing some wonderful work in Rhode Island. I do some national trainings. In fact, I'm recently going to be working with the state of Alaska on this exact topic to do some consultant work for them through a grant. And they are listening and looking at some of the things that Rhode Island's put in place, peer support, birthing hospitals, using all kinds of different mechanisms for making sure that women are taken good care of, ensuring they get on their medication and stay on their medication, all those things, and it's gonna, I think, gonna have a positive outcome for us. The rest of the country is looking at some of those some of those things we're working on. So the Governor's Task Force has a subcommittee that's called SEN, or Substance Exposed Newborns, and that committee meets on a monthly basis, just like the Governor's Overdose Task Force, to talk about implementation plans for this population. But it was only about 4 weeks ago we had a conference for the annual SAN conference, and the big topics for that day were really marijuana, as we begin to look at that. And just the month before, I had done an in-service for the group to talk about alcohol-exposed babies, because we're not talking a lot about that. So we know we have an opiate epidemic, but we also know that we have a substance use epidemic. So it takes a lot of different places.
Yeah, I think, you know, when you look at the pregnant moms and you look at, as you indicated, once they have the baby, then 3 months after that to 1 year, there's times within that 1 year that something happens. Now, what that something is, obviously, I don't know, but you know.
Well, you know.
So what's happening?
Well, even women who don't have an opiate use disorder, and a good portion of our women who have a substance use disorder are going to have a co-occurring disorder. So they may have some history of depression. It's probably not as treated as aggressively during that time. Even women without history of depression and without history of substance use disorder, have what's called a postpartum depression period. That's not unusual. Hormonally, lack of sleep, the care of a newborn, and for some of our women who may not have the means of all kinds of good health care, you know, the ability to get to treatment, the ability to do all these other kind of things, weigh a toll. And then also there's this piece, like everybody else, where recurring symptoms of using again happen. And now that the baby's born and the baby's good and everything's going okay, there might be these urges to use again, just based on the fact that that's part of the disease.
Right. So let me ask you this question. So if a mom is breastfeeding and they're using, does that affect the baby?
If the mom is breastfeeding and she's on either methadone or buprenorphine, which are the two medications that we can use for pregnant women, we can't use Vivitrol or naltrexone for pregnant women. That's contraindicated and cannot be used. But those two medications that are approved and are evidence-based for pregnant women, if they're on those and taking them as they should be, and they're not on any other medications. You know, there are some medications that women can't breastfeed because they're on a medical med that doesn't go well with breastfeeding. So it's not just illicit substances or these medications. But if they're taking either one of those approved medications, they should be breastfeeding. That minimal amount of the medication goes through the breast milk, but just the breastfeeding itself and the different, and the skin to skin and the comfort between the mom and the baby in that moment is actually the best outcomes that we get. So we encourage breastfeeding when moms are on those two medications.
But suppose they're not.
If they're just using on the street, the likelihood of them coming into the hospital and there's going to be a tox screen, and that tox screen is going to indicate that there's something in that urine that's not supposed to be there. The only thing that should be in there is what we prescribed to you, right?
Right.
So if there's something else, the likelihood of her going home with that baby are going to be diminished.
Right. No, my question is, does it affect the baby?
Yes.
Okay.
Because with heroin or other substances, you don't get a steady serum level. You know, you're going to use and be high. You're going to be not using, you're going to be in withdrawal. So you're going to be up and down and up and down. And so that kind of a thing can really impact. The hard part of getting good research around, which is why we had trouble with marijuana, is that if it's a Schedule 1, what's a Schedule 1? All these drugs are scheduled. A Schedule 1 is an illicit drug, heroin. Marijuana, still in this country, but not here, right? But we can't do research on Schedule 1 meds because they're illicit. So it takes time to get around that.
Because I have to do a schedule. I have to go to scheduled break so I can pay the bills. So we'll be right back after this. You've been watching Recovery TV, and I'm your host, Shanta Soni. We'll be right back with Sharon Morello.
And now, back to Recovery TV with your host, John J. Tassoni Jr. Recovery TV is made possible by our supporting sponsors and our title sponsor, AdCare. Now, here's John and today's guest.
Welcome back to Recovery TV, and I'm your host, Shanta Soni. Sharon Morello is my guest today, and Sharon is a nurse, a consultant, and an instructor. Wow. And happy birthday. Tomorrow's your birthday.
It is.
Sharon, I want to talk a little bit about screening. You know, when I go have my physical, the doctor says, you know, do you drink, do you smoke, do you take drugs? Is that happening with women?
It's not happening universally to anybody.
Well, okay.
So women is our special population we're talking about today.
Right.
But as a rule, we're not doing universal screening on these topics at all. And when we need to start doing that, because I've been looking at this since 1980s, working in this area specifically, and saying, why aren't we treating this like other diseases that kill people? You know, we treat, if you're high risk for this, we do screenings for you. If you're a man and that's 50, we're going to do a blood work, and it's going to include a PSA, and that's a blood test that looks at if you might have prostate cancer, because you're at high risk now for that.
Right.
Or whatever those things may be. So if we know that we have a vulnerability here, and we know we do, then we should be universally asking everybody the same questions around substances and mental health. Both.
So your suggestion is to docs.
right in the
may
office.
be watching the show today.
Right in the office.
When your young lady comes in, she finds out she's pregnant, that's when the screening should start, not at the end of the pregnancy, at the beginning.
Exactly. In fact, I would say before the woman's pregnant, when she's 15 years old in the pediatrician's office, that's who should be starting the screening. So we know
Why don't, any idea why we don't do that?
It's the only disease that kills people that we don't do universal screening for. We do blood work for this, we do mammographies for breast cancer, we do, all kinds of universal screenings. The hospitals right now are mandated to ask questions around mental health and suicide.
Right.
I would say right before COVID, I had to take a family member to one of our emergency rooms, which will remain unnamed. And she was hurrying through. The person had a temp of 103 and was really short of breath. She insisted that she had to answer all these questions, ask these questions. One of them was, and she apologized 5 times before she asked the question. I'm really sorry I have to ask you this question, but I have to. They make us do it. And she was kind of blunt. And so finally she looks at the patient and she says, "Are you suicidal?" Well, if he was, do you think he would have answered yes? No, he wouldn't have answered yes. In fact, she made it
Especially the way it was asked.
Right.
Right.
So we can do universal, screening, but we have to do it in an educated, compassionate, harm reduction, motivational, interviewing kind of way. I want to be able to ask you a question. You need to feel comfortable answering it.
It's a long answer, but the short answer is if you're polite and ask the questions the way they're supposed to be asked, we wouldn't have this problem.
It would be a good start. It would be a good start. And we've had, back in the day, it was 1992, big studies across the country that started actually in San Diego that said, how do we predict these vulnerabilities? Who's vulnerable? Not just for substance use, but also for mental health and medical stuff. So they did what's called an ACE questionnaire. Adverse childhood experiences. If you had some bad things happen to you under the age of 18 and you answered some of these questions, there's 10 questions. If you answered some of them more than 5 with a yes, you had a higher 50 to 75% chance than anybody else of getting a mental health, substance use, or medical problem. We had that questionnaire. You know where it is? Sitting on a desk somewhere. We're not using it. What a perfect tool for a pediatrician's office to begin that conversation.
Yeah, you're absolutely 100% right. Because the stories that we get at the Leadership Council is stories of phone calls that we get and questions that we get. It's not the 40 or 50-year-olds, it's the 15 to 24, 15 to 25 questions. And
trauma is just such a big factor, and if we know who's going to be vulnerable, why wouldn't we try to screen out that vulnerable piece?
And a lot of times too, and I'm going to say it, the state, the doctors, they don't understand that if we can nip it in the bud when you're 15 or 16, by the time you get to 35 or 40, there's help already given to you, and you're not in the emergency room.
Right. It's how we treat other medical problems.
Right.
If we screen early and find some things that we can work on, we can develop a plan that helps younger people develop resiliency and gives them an opportunity to not get that disease. So that's called prevention. And we're not doing prevention. We're not doing that. I know there's preventing stuff out there.
Instead of being proactive, we're being reactive.
We're being reactive, and everybody gets so sick that they all have to be hospitalized and all of this. So we've got to change the way we do business, but we've got to educate. So doctors, nurses, social workers, just because they go to those schools for that training doesn't mean they've learned all about addiction. In 2015 or 16, we started our fentanyl epidemic in January 2014. And by the 2015-ish, maybe it was 16, the Department of Health mandated that all nurses get 2 hours of education in addictions. Before that, it was 10 hours in anything you wanted. Now it's 2 hours of addiction. It's mandatory. I started to do some trainings for that and found out when I must have trained thousands and thousands of nurses in the state of Rhode Island. And I asked them the question, did you get this kind of training back in the school? Are you learning about this at all? And pretty much at the end of the day, most of the nurses said to me they hadn't learned this like I was teaching it. I was talking about the brain, the reward center, the frontal lobe. This made all good sense to them because I was giving them the science. So if you educate people, nurses would say, I didn't know that. Now that I know that, when I see this patient in the emergency room, I'm going to act differently towards that patient than I did before. That's amazing that somebody can get educated and make that change.
Yeah, they're also saving lives.
Right, right. I mean, there are some people, no matter how we educate, they're not going to change their mind, and that's okay. But if the majority do, then we're going in that right direction. So we've got to continue that effort. And I think the social work and nursing schools, and I know the medical schools are really starting to address that more. So you see that the newer kids coming out, hopefully, have some education in that. I never received any education on addictions when I was in nursing school. Of course, that was a long time ago, but from what I hear...
How many years have you been a nurse?
Since 1975.
Wow. And thousands of nurses you train. I know you train for the Substance Use Mental Health Leadership Council.
Yep.
And I look at the reviews. They're all glaring reviews that we had Sharon Morello teach us.
I enjoy training. I love when I hear the reviews back after that they changed what they were thinking because they got some new information.
Yeah.
So
you know, and that's the key. You can't. I mean, this system, nursing as a whole. I mean, we got a terrible shortage now.
I know.
But as a whole, and the information that we can give them today is better than the information they got yesterday.
Absolutely.
You know, and we need to get, the state of Rhode Island needs to pay the instructors at RIC and URI and some of the others a wage where they can stay teaching to train more nurses rather than giving $25,000 bonus to nurses in the hospital. They should be giving them the $25,000, and we can put more kids through the training.
Yeah, they're being denied admission into the nursing programs.
Because there's only so many seats.
Right, and that's not just happening in Rhode Island. I have a family member who's now applying to nursing schools across New England, and she's been accepted to 2 in Massachusetts. But one, she didn't get into the nursing program. They put her into, they accepted her into biology because there wasn't enough nursing slots.
Right, we're going to take a quick break, and we'll come back. I want to talk about that new training you're going to start.
Sure.
You're watching Recovery TV, and I'm your host, Shanta Soni, here with Sharon Morello. We'll be right back after these messages.
And now, back to Recovery TV with your host, John J. Tassoni Jr. Recovery TV is made possible by our supporting sponsors and our title sponsor, AdCare. Now, here's John and today's guest.
Welcome back to Recovery TV, and I'm your host, John Tassoni. Sharon Morello is my guest, and Sharon is a nurse, a trainer, a grandmother, a wife. She's everything. She's everything. So thank you for coming on today,
You're
Sharon.
You're welcome. Thank you, John, for having me.
So you got some trainings coming up, and we want to announce it today, and we'll have the people call the Leadership Council if they want to get on.
Yep, I've been working with Substance Use Mental Health Leadership Council, Vicki over there, and we're working on some new trainings coming up. And one of the ones that I'm working on now that I think we will have ready for the spring, so keep your eyes open, is this topic, but even more. So what I'm going to be discussing is the high rate of associated deaths with pregnancy. That's not deaths that happen because people were pregnant. It happens because,
after the fact.
Yes, so we have a high rate of overdose and death in women who are postpartum from 7 to 365 days. So we're going to be talking about that. We're going to be talking about intimate partner violence, which transcends all of those things. The highest rates of associated deaths are suicide, homicide, overdose, and then we're going to talk about treatment of opiate use disorder, alcohol use disorder, and just alcohol use at all, because none can be done, marijuana and stimulants. We'll talk all about that. It's a 6-hour training, hopefully in the spring.
Well, thank you very much for coming on today, Sharon. If
You're
anybody's interested in that training, give us a call at 401-521-5759 and ask for Diane, and we'll get you registered for Sharon Morello's class. You've been watching Recovery TV, and I'm your host, Shanta Soni. We'll see you next week with Tom Cordair.